hemoglobin. You can certainly get a CT scan of the abdomen and pelvis, look for bleeding. You can look for a leak. You can do a CTA, like Dr. Todd mentioned, CT chest P protocol to look for Ps. You can certainly do venous Dopplers to look for DVTs. Those are certainly pretty sensitive, even though they are operator dependent. This is all in the post-operative phase, but I also want to make sure there is a very defined role for imaging in the pre-operative phase. So for example, if you look at the position statement of the American Association of Clinical Endocrinologists, the Obesity Society, and the ASMBS, they came out with a joint statement in 2013. It clearly mentions or recommends preoperative DVT screening patients with a history of DVT or someone with a history of cor pulmonale. Again, I'm sure a lot of us do this in our practice. Right upper quadrant, limited ultrasounds. If you want to factor in any history of biliary colic and whether the patient has pre-existing cholelithiasis, you may potentially want to do a concomitant cholecystectomy, if that's the case, along with your primary bariatric procedure.
Thank you, Dr. Vasan. Now, there are other criterions which have been talked about, but then we move on to the next important question. Does these patients need thromboprophylaxis at all? And Dr. Subiraj, what are the principal types of chemothromboprophylaxis we have for using?
Yeah, could you just help me share my slides?
Yeah, just a moment, sir.
Yes, let me just come back to it and show you what is being advised in literature and you know, what we do also. So just get to that slide. I think the first thing you need to do, which we all do, is do a very good risk assessment to give you an idea of where we stand. So that is the first thing. Sorry about that delay. Yeah. So that gives you an idea what kind of prophylaxis comes up. So your grading of risk will decide what kind of prophylaxis you will give. So general measures are there for all patients. Mechanical prophylaxis is recommended for all bariatric surgery patients. This is limited by people who may have severe lymphedema or lower extremity issues. The role of chemoprophylaxis becomes mandatory because, as is mentioned by others, people who come for bariatric surgery are moderate to high risk, and they automatically come into multimodality prophylaxis. So you have to add on chemoprophylaxis for most people. Now, if there's a risk of bleeding, you will have to temper that. So your risk assessment will also have to involve the risk of bleeding around surgery. Now, I won't get into this because I think somebody else is doing this, but low molecular weight is better off than unfractionated. You also have to understand, in terms of type of prophylaxis, how long and how much prophylaxis will you give, because most events seem to occur in the first 30 days. So that will again depend on your assessment and the grade of risk. IVC filters as the only prophylactic method, not recommended.
Dr. Sivaraj, I'm sorry to interrupt. Somebody is going to talk about that.
Okay, I'll stay out of that. So I'll just tell you what we do. So I'll just run through that quickly. So besides the assessment and general measures, we give chemoprophylaxis 12 hours prior. We're giving a straight jacket in our case, 60 milligrams of enoxaparin. And we started 8 hours post-surgery. We put in a graduated compression stocking, which is customized for each patient, either below knee or above knee by individual consultant preference. We are careful to avoid tourniquet and pressure harm. And then we have this on before induction and also put on an intermittent pneumatic compression device prior to induction of anesthesia. Very important. This has to come on prior to induction of anesthesia and continue till the patient is ambulant, especially continue for people who are paraplegic. And then patient is ambulated as quickly as possible, even as early as an hour and a half to 2 after surgery, and continued this aggressive ambulation in the post-op period. That's very, very important, and we follow this up when the patient is home by our nursing home care, follow-up. So a good assessment will give you what kind of prophylaxis, general and mechanical prophylaxis for everyone, both graduated compression stockings, which are customized and well-fitting. And then we add on the intermittent pneumatic compression device prior to induction of anesthesia, especially muscle relaxation, and then continue till the patient is actively ambulant in the hospital. And we even continue at home for certain high-risk patients and those who are immobile. So I hope that answers your question there.
Thank you, Dr. Subiraj. Can I request you unshare yourself, please?
Yes.
Now we move on to the next important challenge. Excuse me. Praveen, you have been working on something very, very challenging and different. You went on to hit on to the next target, whether all these things are getting overdone. So does it mean, from your experience, all these things are a little bit over safety measure, and are we trying to over medicate this patient? This is the next important question. So with so little incidence, everybody is quoting less than 1% or even single digit in somebody who has done 7,000 series. What is your take on this, Dr. Praveen? Do you think we are overdoing things here?
Yes. So this publication that we had a couple of years back, we titled it, this was actually the title of the whole paper, Are We Overdoing? So what we tried to do was, this all started from the same discussion. So we've been hearing a lot of surgeons in these panel discussions who actually have very small numbers of DVT and pulmonary embolism. Not just in India, this I have heard it from many centers across Asia, including Dr. Vijay Lee's center from Taiwan, where they have done up to about 15,000 bariatric procedures without chemoprophylaxis and only mechanical prophylaxis, and he reports 0 incidence of a DVT. So similar kind of incidents predominant of the Asian centers do have. But then the guidelines that we are all following today with regard to unfractionized heparin or the low molecular heparin have been from the experiences of the West. And we have a lot of data from the Asian side that the incidence of DVT and PE is much lower compared to what we have from the West, maybe because of different reasons, ethnic differences that are actually there. So we are trying to create guidelines and protocols based on the West. However, there are a lot of centers who are really not having great prophylaxis as such. And with just mechanical prophylaxis, they've been able to give the similar incidence that many of us are giving, even with the chemoprophylaxis. So when we went on to do a survey across surgeons in the Asia Pacific, about 19 surgeons, we tried to do a survey. Around 30% of the patients were using only mechanical prophylaxis, and 70% of the surgeons were using both chemo and mechanical. However, way lesser than the published guidelines of the West. So I think, yes, we need to have a guideline. We need to make sure, we need to ensure safety of the patients. We need to follow early ambulation, surgery to be fast. We need to risk optimize the patient, understand the cumulative risk. However, we still do not have a clear-cut point to say this is what is ideal, because sometimes overdoing can actually increase the chance of bleeding risk, and many times ecchymosis, not just bleeding as such. Many patients complaint was with ecchymosis all around, or having it for days together, which takes time to reabsorb. So I think we need to weigh the risks and the benefits of underdosing and overdosing.
Point is well taken, Praveen Raj. I think someone has to think about the other end of aspect. Either non-doing or doing it or overdoing it is being to be kept in mind when considering treatment in these challenging patients. Now I move on to the next important thing. Dr. Nitin, I'm going to ask you, are all bariatric patients, I would say, how do you stratify the dosage? How do you want to space the dosage? What is the optimal dose you feel it is a right thing to do for these patients? Dr. Nitin, please unmute yourself, Dr. Nitin.
So coming to the right dosage of low molecular weight heparin, This is the large study published from Finland, which is involving about 400 patients who underwent sleeve gastrectomy and RYGB. And they studied 3 different doses. That first was high dose, in which they gave 40 milligram twice a day. They also given LMWH on day of operation and post-operative day 1 also. And in intermediate group, they given 1 day before 440 milligram BD. And in low dose, they given just a 1 dose prior to the surgery. So in that study, they have found that there is no incidence of thromboembolism in this 400 patients cohort, but there is an increased incidence of bleeding in patients with high and intermediate dose group as compared to low dose. So once daily dose is optimal, increased frequency or dosage has not shown any benefit, and there is an increase in the risk of adverse events in the form of hemorrhage. So currently the standard of care is a once daily 40 milligram dose preoperatively.
Thank you, sir. Thank you so much. Dr. Raman, the next important challenge is, my doubt will be, am I doing it adequately? Or is the patient having an effective circulating dose of medicines? Or is there a way to tell, okay, your prophylaxis is adequate from the chemoprophylaxis point of view? How do you monitor these patients, Dr. Raman Goval?
Okay, well, I think there is, it's not really required to monitor these patients. As we just saw that Praveen Raj said that, are we overdoing it? So I think monitoring every patient will be overdoing it. We must be more practical, because we know that if we are doing adequate dosing, not doing overdosing, then in majority of the patients, when we are talking of 0.03% in India, it's really a very small fraction of patients who might have this in first 1 month. So I think this monitoring that you have mentioned, you are monitoring the anti-10A levels post-operative, is not really required. We don't need to even titrate the dose against the weight of the patient. This was a major issue a few years back, maybe a decade back, that when we will do a surgery in Bombay Hospital, I remember the physicians will say 4,000 units is a pediatric dose for your patients, is 160 kg patient. How can you give this? And we indeed had higher bleeding rates in those patients in those days. So I think now we have a realization has settled in. Once daily dose, you can give 4,000 units as we do it, but some people prefer 6,000 units, and that's it. And we don't monitor. And and since we are doing many other things, I'm sure somebody else is covering the ERAS protocols, hydration till 4 hours before surgery, mobilization, shorter operative time, adequate hydration, everything matters to. So I don't think we need to really monitor dose of this chemoprophylactic agents and its impact on the thrombotic episodes in the patient.
Thank you, sir. Now we move on to the next important area. Now everybody feel, okay, I don't want injections, or can it be 1 dose or 2 dose and I'll be having an extended coverage? Dr. Narvaria, sir, what is your take on the role of the newer drugs, NOACs, the role of pentasaccharides in PT prophylaxis?
Sorry, I could not get through this. You mean the new medicines, chemoprophylaxis?
Yes, sir. Yes.
There's an effort trial which is published, which I could see that was the only trial which has seen the preoperative enoxaparin versus fundaparinux in post-operative period, and it has shown the fundaparin having better result compared to enoxaparin alone. So that is the effort trial which is published.
Thank you, sir. Now I am going to ask Dr. Arun Prasad, sir. I don't want injections, doctor. I am very scared about injections. Do you consider oral drugs will have a effectiveness as similar as injectables, Dr. Arun Prasad? What is your thought on this?
Yeah, so there has been a lot of debate and discussion regarding the oral anticoagulants, and still we don't have clear directions over here. What has come up are few medicines which are, rivaroxaban, then there is an apixaban, I don't remember the name so well, and there is one dabigatran. So these medicines, the problem is that the bioavailability of these medicines are dependent upon a glycoprotein which is produced by our intestine. So this glycoprotein actually inhibits the absorption. So more of the glycoprotein is produced in the terminal ileum, and less of this is there in the duodenum. So when we have a patient, say, undergoing a bypass surgery, the drug is going to get less absorbed because it's going to bypass the duodenum and go towards the ileum where the inhibitory factors are more. Similarly, we also know in sleeve gastrectomy, the gastric emptying is being reduced and the food moves faster. So these medicines which are, activated in the stomach, they don't get enough time in the stomach. In the bypass, it's going to bypass immediately. In the sleeve also, it does not stay for long enough. So the bioavailability of these drugs is a big question mark. Hence, we are not sure of how well they are going to work. There are other medications, which is, apixaban, which has come, that says that, it's going to get better absorption and it's less affected by the glycoprotein. But we need more studies on that. The third medicine which was there, which is a dibictagram, now that medication is an antithrombin. The problem with that is that it can lead to stomal ulcers. So when we have got bypass patients, you are giving something that can lead to stomal ulcer and it can cause bleeding. So there is a lot of confusion here, and nothing, oral ones are not yet approved for use in bariatric surgery. Warfarin was thought of. Now warfarin, wherever it has been tried, it has led to increased bleeding. So that has also been stopped. So currently, unfortunately, we still have to stick with injections, as my other speakers have been talking about.
Thank you, sir. Jayashree ma'am, the next important thing, in fact, you touched upon the issues which pose a higher risk to these patients to have a possible VTE. When do you think you will consider IVC filter in these patients, madam?
IVC filter, yes, it is indicated, no doubt about it. But the safety and the efficacy of IVC filters is not yet been proved. Number one. Number two is IVC filters should be put in prophylaxis of prevention of the PE in patients who have got a strong history of DVT and history of PE already in the past. So these become the tremendously high risk category patients with the score which is more than 1. So in these patients, IVC filters can be given a good thought about application. Typically, in those patients where you cannot give mechanical prophylaxis and also the chemical prophylaxis, in those patients, IVC filters are strongly recommended. Like the patients who have got typically, suppose, very high BMI, paraplegia, history of DVT, history of PE, and the patients where you may not be able to give very high doses of the chemical anticoagulation, then these will be the people. So you have to take the decision about IVC filter, taking into consideration a thorough discussion with your cardiovascular colleagues. And this is how it is proven even in the literature till date.
Thank you, madam. Thank you. Dr. Vasant, I think I'm going to ask you one question in between before we run into your question. There is a question from one of our senior colleague, Dr. Pramod Shinde, in the chat box. He asked, do you get venous Doppler of the lower limbs as a pre-op mandatory test in all patients? As you rightly said, many of them may not be positively symptomatic, or you really don't know whether they have already having a silent thrombus inside somewhere. So what is the take on preoperative venous Doppler, do you order for all preoperative patients, Dr. Vasan?
So I think I touched upon this when I talked earlier, and this is based on the position statement of the American Association of Clinical Endocrinologists, the Obesity Society, and the ASMBS. They issued a joint guideline statement in 2013, which basically said that recommended preoperative DVT screening in the form of a venous Doppler only for patients with a prior history of DVT or someone with a medical history of cor pulmonale. These were the only two categories for whom preoperative screening was indicated and recommended.
I think that very clearly answers to Dr. Pramod Shinde's question. Now, your question in the order. Dr. Vasan, we have been talking about PE, cough VTEs, and other things. What is your take on, is there a possibility these thrombosis can happen in some other zones, a more scary zone? Do you have any experience personally on this, or have you seen somebody narrating their story? How serious are these conditions, or rather unfortunate situations a bariatric surgeon may face?
So yes, absolutely. I think, it's very important to understand that the eye doesn't see what the mind doesn't know. So you got to be willing to consider some of these lesser known or lesser considered possibilities that I think some people had briefly touched on in the past, including splanchnic thrombosis and portal vein thrombosis. So mesenteric thrombosis is a rare but potentially lethal complication that can happen in patients who undergo bariatric surgeries. The incidence is not high. It's in bariatric surgery literature, it's about 0.3 to 0.4%, depending on which studies you want to look at. But specifically in sleeve gastrectomies, the incidence is about 1%. And yeah, there are various risk factors. In fact, dehydration is a very important risk factor that can promote mesenteric vein thrombosis. Now, you have to maintain a high index of suspicion with these patients in diagnosing these conditions, else you may potentially lose the patient. Most patients typically initially present with a new onset of epigastric pain, about an average of 10 to 15 days post-operatively. So patient's gone home by then, and they may not present with some very significant symptoms. They may just endorse some pain radiating to the back or to the left scapula. They may talk about some nausea or vomiting. As everyone knows, these are all symptoms that any patient who's had bariatric surgery may complain of, but you have to be able to put 2 and 2 together. And, CT scan with IV contrast will be the diagnostic modality of choice. And if you diagnose something like this, a mesenteric vein thrombosis in the form of a SMV thrombus or a portal vein thrombus, your initial treatment is going to consist of IV hydration, bowel rest, and anticoagulation with either low molecular weight heparin, or you can use IV unfractionated heparin, and you have to follow through with the initiation of oral anticoagulation. Obviously, this is all for a patient who's otherwise stable. I'm not talking about a patient who's presenting with peritonitis. If you're having a patient clinically presenting with peritonitis, or you have CT scan findings concerning for bowel ischemia, you need to do an emergent exploration with possible bowel resection if the intraoperative findings warrant that. And in such a case, you should always plan for a second look surgery. Don't be satisfied with the fact that you identified the problem, you got the dead bowel, and the problem's taken care of. You should always plan for a second look laparotomy, or at least a diagnostic laparoscopy in these cases. And the workup, and then you definitely need to do a workup for thrombophilia. That's definitely warranted. Long-term anticoagulation in these patients is typically recommended for up to 6 to 12 months, depending on your practice pattern. And sometimes you may even need, in an extensive thrombus in the portal vein, you may even need to consider a direct catheterization of the portal vein with thrombolysis, and that's certainly been described in literature too.
Have you come across one of these unfortunate situations, Dr. Vasan?
I've thankfully, thank the good Lord, never had to deal with one of these. But having said that, I am part of the Michigan Bariatric Surgery Collaborative, and I think a lot of folks on the panel know that a lot of the seminal data, even the data with regards to the IVC filter, mesenteric vein, mesenteric thrombosis, a lot of it comes from the Michigan Bariatric Surgery Collaborative. And because I'm part of the collaborative, I've personally talked with other bariatric surgeons in the collaborative who have had to deal with this unfortunate situation. And few of them have actually lost patients. This was picked up post-mortem, but it's just a difficult problem to diagnose. Diagnosis is the key. If you diagnose it, you can deal with it successfully. But that's why I started out my statement prefacing, you have to maintain a high clinical index of suspicion. And if you don't know what you're looking for, you'll never find it.
Yeah, in fact, I encountered 2 such patients, and we could manage by chemoprophylaxis.
But how many days post-operative you face this problem, Dr. Narvaria?
Maybe after 2 weeks.
Yeah.
One
so they were back at home.
Yeah, they came back with pain, which was then evaluated, and we found this as a findings, and we treated them on the long-term LMWH.
Thank you, Dr. Narvaria. Thank you, Dr. Vasant. Now we move on to the next question. VT management and in general, and VT management in bariatric procedure. Dr. Subiraj, do you think the same algorithm fits in, or you have a different parameters for bariatric VT management?
Yes, thank you. Could you just unshare, because I think that's a wonderful algorithm. We'll come back to it. I'll just share something maybe more point-wise, and I'll start with where Dr. Vasant left off. Your clinical suspicion is king. That is what is going to actually drive the algorithm, the management, because the presentation can be extremely non-specific and variable and confusing. If something is very obvious, yes, you can take it along, but often these can be confused for intra-abdominal complications, and then you could head the wrong way. So you have to sort this out very quickly, and that depends on your clinical threshold and suspicion. Now, having said that, you can do a classical risk assessment clinically, but generally we are blessed with a multidisciplinary approach in most tertiary hospitals. You have a cardiology or a vascular physician who comes and helps you out. Do the basics very quickly, get a 100% oxygen supplementation and IV access, shift the patient to a high dependency unit or the ICU, get the investigations gone, analgesia if required, keep assessing the circulation. And once you've done these basic tests, as Dr. Others alluded to, I think you can then quickly plan a CT angiography of the thorax, and then also do a quick CT abdomen along with it. And if you have time, have the vascular physician get a quick leg Doppler examination done. This will give you a good initial assessment along with your clinical presentation. Now, the initial management then depends on the degree of severity of presentation. If it is a submassive pulmonary embolism or a low-risk pulmonary embolism or a DVT, that's essentially a hemodynamically stable patient, or somebody who's stable with a right ventricle dysfunction on echo, for instance, or some myocardial necrosis turning up on the enzymes, you have to anyway start with systemic anticoagulation, which is basically unfractionated heparin. I'll come to the details. The role of thrombolysis in this is a little controversial. I'll stay out of it right now. Those with massive pulmonary embolism, essentially those who are unstable with a systemic, arterial pressure of less than 90 millimeters of mercury, start systemic anticoagulation and plan for emergency thrombolysis, essentially recombinant tissue plasminogen activator, one of the options there. And as I said, your first line should be your systemic anticoagulation. You can start it in the ward or in the high dependency unit or the ICU, a bolus of unfractionated heparin followed with an infusion for at least 24 hours or till the patient is stable. You can make a switch once the patient is stable to a low mercurate heparin, aiming for a APTT value of about 2.5 times for the first 24 hours.
Dr. Subraj, somebody else is going to attend to this. I would say at this point, we will stop your slides, but I want to have a clear answer from you.
Yes.
A bariatric VTE algorithm and a conventional VTE algorithm, are they pretty much the same and good? If there is a difference, what are the principal difference between these two algorithmic approach?
You can come back to your slide, which you had there initially. You can share that. 1 second. I think, first of all, the degree of confusion is high. So your level of suspicion has got to be, really, really high on this about detecting a pulmonary embolism. And then, you base it on that, but you have to really look at the other options of, dealing with a concomitant intra-abdominal problem also. So I think that's going to be my main worry in a bariatric patient. Otherwise, the algorithm is going to run pretty much the same. And especially in a fresh patient post-op, you have to be really concerned about GI bleed, which is going to be a very worrisome thing. And then have your gastroenterologist, on their toes. So you have to be really on top of your game, not just you, but your team, and get your blood ready, backup for GI bleed or extra intestinal, intra-abdominal bleed in this case. So that is going to be a thing in a high-risk patient. So that is going to be the difference, unlike a regular, maybe a GI surgery patient.
Thank you, Dr. Sivaraj. In fact, you brought out the pertinent points. The risk of bleed and the overweight aspects of the surgery, what we are planning and we are doing, add to the risk of add to the challenge of the conventional algorithm. Now, I think we need to catch up little time to touch upon all bleed videos. I'm going to run through the questions. So I would expect the faculty to have a snap type of answers. Dr. Praveen, when do you change these patients from injections to oral drugs? In your practice, how long do you give injections? And do all patients need a change toward oral drugs? And if yes, when and how?
This question is with regard to development of DVT, am I right?
I would say first let us address about prophylaxis, then address about patients who have developed VT. We can have two ways of looking at this problem.
Let me be quick. So with regard to prophylaxis, the low risk patients for 7 to 10 days of low molecular weight heparins, for high risk patients up to 4 weeks. I think oral drugs may not be needed, although there are some studies on rivaroxabans. With regard to the treatment as such, of course, in the past, we used to start with low molecular weight heparins for about 7 to 14 days. We would gradually shift over with about 2 to 3 days of overlap with warfarin or coumarin and continue for 3 to 6 months. But with the exabans that is available, the highly selective 10A inhibitors, like the rivaroxabans or the apixabans, so they have to be continued for a minimum of 3 months or up to 6 months. This is for patients who have developed DVT, because their interference with the blood profile is very, 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 very little. They're very safe, so they can blindly be taken without any monitoring of the INRs.
Thank you, Dr. Praveen, for a crisp and quick answer. Dr. Nitin, I'm going to ask you. Sir was telling about some patients may need extended use of these drugs. Nitin, with your viewpoint, who are the patients who will need extended prophylaxis, and what are the specific situations people may end up having more than a year or more than 2 years of continued prophylaxis or continued prevention prophylaxis rather?
So we need to remember one thing, that more than 80% of post-bariatric surgery develop VT after discharge. So the patient who have a congestive heart failure, paraplegia, dyspnea at rest, and who had a history of reoperation are associated with highest risk of post-discharge VTE. So these people required a post-discharge pharmacoprophylaxis for longer period.
Thank you, sir. Dr. Raman Goyal, sir, I'm going to ask you a different challenge now. You put on all the medicines. You plan to do a elective revision, or you plan to do some form of correction on an elective basis. So how many days we will again take this in two aspects. One is on regular prophylaxis, one is on treatment, which is for a VTE, which has happened in the post-operative period, and on high-dose oral anticoagulants. These are the two problems which you have in hand. But then you want to revise the surgery for some reason. You feel the sleeves are not as tight, or let us not talk about the indication part of it, but you want to do an elective reoperation. How do you approach these two areas?
So I think that's an interesting question. And nowadays, not only because of bariatric, but because of the cardiac issues, a lot of patients come with oral medication before surgery, and they form the bulk. And these are the patients which are typically kept off the oral medication for at least 5 days before we plan an elective surgery. And usually it's a good idea to engage the cardiologist who has been treating, or the physician who had been treating, in managing this, and we shift them to the subcutaneous dose during that period. Usually patients who are on aspirin, we don't stop that, because now it is considered a small 75 milligram aspirin need not be discontinued before surgery. So this is for the elective preparation of these patients. Patients who are on blood thinners after a surgery, and suppose there is a leak or there is a bleed inside, then with 4,000 units, it's really not a big issue. The first thing is that we stop this and we plan for our surgery. And in my practice, I overrun all the staple lines irrespective of where the bleed is from or where the leak is, because the possibility of bleed is again there after surgery, because the patient is on blood thinners, and we want to start them on blood thinners early. Because of a second surgery, the risk of thromboembolic phenomena increases. So we want to stabilize them fast. We want to start them again on blood thinners as early as feasible. So I think these are the considerations that need to be kept in mind when we are doing a revisional surgery.
Thank you, sir. Dr. Vasan, now
Yes.
we attended to something on elective basis. See, a patient lands up in somewhere around 2 months or 3 months on thromboprophylaxis with GA bleed. The medical gastroenterology colleague says, sir, I think it is something wrong on the anastomotic line, and endotherapy doesn't seem to work. What next? Do we stop the drugs of a therapeutic thromboprophylaxis and try? Or there may be some occasions where you end up requiring a rapid re-entry in the, I would say, 20-30 days post-operative period. How do you quickly reverse the effect in a potential revision intervention?
So, typically with the thromboprophylaxis, unless you're in an extended thromboprophylaxis situation, you're not going to keep the patients on at the 3 or 4 week mark. But let's assume that you have a high-risk patient who's on extended thromboprophylaxis. Unless the patient is in circulatory shock, you do not need to usually stop the venous thromboprophylaxis. Typically, you'll be able to figure out what the cause of the bleed is. I mean, like you said, if this is an anesthetic bleed from the gastrojejunostomy, all you might need is therapeutic endoscopy in the form of, putting a couple of hemoclips on the anastomosis, or maybe using some electrocautery. If it is thought to be at the lower anastomosis, let's say the jejunostomy, you may need to do a combined approach. Laparoscopically, you may need to go in and you may need to thread or milk the small bowel over the endoscope so that the endoscope can actually reach the level of the jejunostomy. And then you can still do your therapeutic endoscopy. Source control is what's important. You can't hope to stop your Lovenox or enoxaparin or heparin, whatever the case may be, leave a pumper alone and then say that, oh, I dealt with the problem. You just can't do it. Source control is paramount. And so I think that's the most important. Sometimes you can have a delayed bleed from the gastroepiploic arcade or the short gastrics that you take down, and you may need to go in. And all it may take is, a lot of times when you go in like that, you'll just see a blood clot. Typically, you don't see active bleeding. But if you do see active bleeding, just put a suture ligature or a hemoclip, and that should be enough to take care of the problem. And typically, you do not need to stop thromboprophylaxis. Remember, when you go in for a reoperation, you're actually increasing the chances of a VTE in these patients, and you don't want to take a step back by stopping the thromboprophylaxis. And just commenting on the slide that you put up, I see that you noted that fondaparinux, it's Arixtra. There is no known reversal agent. That's what the slide says. I think we do have some agents that can help. I just wanted to say that, we have andexanet alpha, which is a catalytically inactive form of factor 10A, which is able to sequester direct factor 10A inhibitors, and it's effective. It's going to be effective for reversing indirect acting factor 10A inhibitors like fondaparinux, rivaroxaban, and apixaban. They're going to work for these drugs. You can also use activated prothrombin complex concentrates, APCC, or FIBA. FIBA is a factor 8 inhibitor bypassing agent. Both those do not work completely, but do provide some level of reversal of fondaparinux activity. So just something to keep in mind. You don't have to think that I don't have any options available if I'm using fondaparinux or Arixtra.
Thank you, Dr. Vasant. One closing comment from you on this particular point. Is there a role for hemodialysis or pheresis in these patients who take through these drugs for a rapid reversal?
Absolutely. That's the Hail Mary pass. If nothing else works, that can certainly be tried. And some of these agents are certainly amenable to hemodialysis in removing the effective circulating active principle. Yeah.
That's a point everybody should keep in mind as a last savior. Sir, Dr. Arun Prasad, everything what we have talked, the ERAS team says, okay, come on, your guys are going to follow ERAS. To be precise, ERABS. Can you quickly highlight what are the core components? And I think we are almost 2 decades following ERAS for bariatric procedure. So we have a very large experience on that. Quickly, I would say your consolidated viewpoint of role of ERAS. Arun Prasad, sir, over to you.
Yeah, I think most surgeons are, bariatric surgeons are following ERAS right from the beginning, because bariatric surgery has actually changed the way post-operative recovery takes place. Before bariatric surgery, after a gastrojejunostomy or a resection anastomosis, people used to be kept NBM for 3-4 days. Bowel sounds, passing of flatus, passing of motion, all sorts of things were done before oral fluids were started also. So what is important now with bariatric surgery point of view is, we will look at it from both pre-op and hospital point of view. Before surgery, things like, stopping smoking, improving your diabetic status. Then patients who may be, on CPAP, they have to be optimized. So optimization of the patient is important. I know it cannot always be done, but that definitely helps later on after surgery. Patient should be allowed to eat, say, light snack till about 4 hours before surgery, oral fluids till about 2 hours before surgery. Then things like admitting the patient straight away in the morning and taking the patient to the operation theater, that helps. During anesthesia, again, it's important that the anesthetist avoids opioids and other drugs which can lead to post-op ileus. Then complete reversal of paralysis has to be done, and patient has to be really made up and about in the recovery itself before moving to the ward. They should be started early on, starting with water, early mobilization, DVT prophylaxis, yes, which is being given, and compression stockings should continue with that. Next day, we should teach the patients how to, give their own DVT injections at home and try and discharge them. So we've been doing this for quite some time. So I would say about 80% of my patients are ready to go home the next evening, and 20% stay on for longer following this various ERAS protocols.
Thank you, Dr. Arun Prasad. Now we move on to the next I would say, a closing question, but then most difficult question for any one of us, or most difficult challenge any one of us would ever prefer to face. Jayashree ma'am, what is that global data on lawsuits on bariatric surgery still? Where is VTE coming on the line for legal suits on surgeons? They say you are negligent, that's why we developed VTE. You failed to diagnose VTE, that's why we lost our relative. These are the various things. When everything goes well, you are a god. When something does not go well, then they say you are negligent. So with that keeping in mind, what are the core issues? I would say documentation, all those regular things can be fine. Pertinent to bariatric surgery, what are your salient points which someone have to be safeguarding from professional point of view?
As far as the mortality, perioperative immediate mortality in bariatric surgery is concerned, DVT and PE have got a very high rank, I will say, because that is something where we can try and treat the patients. But unlike the bleed and the leaks, not everything is within the control of a surgeon, number one. Number two is, as far as the lawsuits are concerned, it can be, if we go through the literature, there are various types. Like some time back, Dr. Pramod Shinde asked about whether venous Doppler study needs to be done in all patients or not. Above the BMI of 35, it is recommended that venous Doppler studies should be done for lower limbs in all the patients undergoing bariatric surgery. Second thing is patients who are, so this is about the diagnosis and high index of suspicion. Again, the coagulogram is needed. Number two is the patients, all preventive prophylaxis, whether you have done or not. So let's not miss that 0.4 ml of Clexane or 0.6 ml of Clexane at least 4 to 6 hours prior to the surgery. Mechanical prophylaxis is also very important. So documentation of all the things in terms of diagnosis, high suspicion index, third part is the prevention strategies. Fourth thing is post-operatively taking care of the ambulation, hydration, and if need be, within 24 hours starting the anticoagulation again are important things. The fifth part, which also needs to be emphasized, it's about the convalescent period. When the patient is getting discharged and going home, whether the detailed instructions are given to the patients and whether they have understood or not. What we have learned from many others is when we give any instruction at the discharge time, because it is something which is not under control of the hospital staff, again, we make it a point that we inform the patient and take the signature of the patient and the relative both, that yes, we have understood this and it is for the safety of the operation that we must follow. I think these will be the guidelines which must be followed. And of course, we cannot be negligent at any point of time. Negligence can be in the diagnosis of the event. So you have not suspected, you have not done the dimer and the saturation is falling, then it is your fault. The second fault can be whether you are having any linkage and connection with any big center where your further major imaging and further ICU backup and the pulmonology and cardiac backup is available or not. So like the International Center of Bariatric Surgery, we have to keep all those things ready. If we go through the International Center of Excellence criteria, we will know that all those things which are needed to play safe game are mentioned there, and that remains one of the very strong points to work to save ourselves against the lawsuits.
Thank you, madam. Thank you so much for covering up the entire gamut of legal issues.
Could I add one point to that, Dr. Kanaguyal?
Please, Dr. Suviraj, go ahead.
Yeah, I'll just share something if you don't mind. This is from India, because it's India. I'm just sharing that with you. You need to understand that in India, I got this from the Supreme Court. 3 out of 8 legal rulings on VT-related deaths, again, non-bariatric, have gone against medical doctors in India, so you have to be careful, especially with articles like this in the press. Please also remember, we have legal liability because under the National Patient Safety Implementation, VT assessment and protocol is now mandatory. Government of India, Ministry of Health and Family Welfare. And the draft guidelines are coming out maybe sometime this year after the COVID problem sort of lightens up. And under the NABH, now VT assessment and follow-up strategy is mandatory as part of NABH accreditation systems. So you need to be aware about this, and in your hospital, have a written protocol and policy for every department, if not for the institution. Thank you.
Thank you, Dr. Suviraj, for sharing that point. Now we move on to this next important thing, the bleed management as such. So this is how the bleed management videos are going to be shown. Few of them have a couple of videos also. So now the first savior for any bleed management is endoscopist. If something can be done without a surgery, from both by patient's point of view as well as the operative surgeon point of view, that gives you a big relief. Dr. Nitin, can you share your experience in this bariatric bleeds? I think you'll show the first video, then we'll have a surgical video and come back to your second video a little later. Is that fine, Dr. Nitin?
I have very short videos. I'll show 2 videos, and third video you can come back.
Okay. Go ahead. You can share your screen, Dr. Nitin.
Thank you very much for giving this opportunity. The management of bleed in post-bariatric surgery is teamwork, and we do to improve our outcome, to reduce mortality and reduce morbidity and prevent mortality. So coming to the incidence of overall complication in post-bariatric surgery is now declining. However, a bleed after surgery is one of the major complications, and it can be acute or chronic. Early post-operative bleed is usually due to staple line bleed, and it's very difficult sometimes to access excluded segment of intestine like stomach and this root limb, and we may require device-assisted endoscopy or endoscopy through the gastrostomy. And the marginal ulcer, the factors which causes marginal ulcers are local ischemia, staple line disruption, and risk factors are such as like gastrogastric fistula, H. pylori, smoking, and NSAIDs, or excess gastric pouch length. So I'll show these 2 videos. These 2 videos will demonstrate when you may not require any endoscopic therapy in such cases. A small ulcer or multiple small ulcer, you don't require anything. Or if you have very large fibrotic base ulcer like this with some surrounding hyperemia, these patients usually present as a chronic bleed, and they may not require any endotherapy. So these 2 types of ulcer you can see here, which is having a large clot adherent to the base. So we are using a snare which without any cautery, just to expose the bleeding vessel, and then you can apply hemoclip and achieve the hemostasis. And this another video, you can see there is a diffuse ooze from the ulcer base, and there is one vessel, and you can inject 1:10,000 to 1:20,000 adrenaline in 1 to 2 ml in all 4 quadrants, and followed by contact thermal endoscopy. Okay, so I have demonstrated 2 therapies. One is injection and one is clips. The injection works by tamponade and clips by mechanical compression. There are various clips available which are comparable to each other with some difference in the price. Over to you, Dr. Kananga.
Thank you, sir. That has given a preliminary view. Now we go to more challenging ones before coming back to you. May I now request the video from Dr. Mahendra Narvaria, sir. Can I request Nitin to unshare your screen, sir, please? Yes. Narvaria, sir, over to you, please.
Sure. I'll just take this video. I don't know. Oh.
You want some time, sir? Can I have the next video and come back to you?
Yes, I need to just.
Dr. Vasant, in the meantime, how often your patients have needed an endoscopy or endotherapy in some form for bleeds? Please unmute yourself, Dr. Vasant. Vasant, you are muted.
Can you see this now? Can you see my screen?
Yes, sir. Can Vasant answer that question, sir? How often you get to see, Vasant, your patients needing an endotherapy?
So actually, in my personal experience, I've just had one case like that where I had to go in and just clip the gastrojejunostomy. There was a little pumper with a base that was exposed, and that was that. But I've also had once to go in with a diagnostic laparoscopy for a bleed from a little tear in a splenic capsule. But that's obviously a solid parenchymal bleed, just needed a surgical application, and that was that. Just 2 instances so far.
Thank you, Vasant. Narvarya sir, over to you.
So this is creation of rulim, where I fired the first stapler to divide the bowel, and now I'm extending this on the mesentery using a ligature. And when I'm going close to the base, I encounter this bleed. So crux here is that keep the field clean, keep a suction around, and have a patience. Don't try to control it as fast as possible. So everybody is moving slowly, precisely, without obstructing the view. And you can see this. So still it is with this ligature, but then I took the suture to control this. So this is you can see the spurter, the blood vessel which is bleeding. And this is endostitch, which I usually use. And taking this and taking this, you can see the vessel now clearly. So this exposes it completely, and then you can take sutures around and close it. So this is one, and one more which is commonly we see in sleeve gastrectomies when we do the posterior dissection. So maybe 2 such videos.
You have the next video available, sir, or I will come back to the next video after the next person?
Yeah, I think we can do that. If we have time, we'll show. Otherwise, I think we'll move. We're already too late.
Now I ask Dr. Nitin, can you show your next endotherapy video, sir?
Are you able to see the screen?
Very well, sir. Please go ahead. We are okay.
So this is the patient of Roux-en-Y bypass and presented as an obstructive jaundice. And we try to do a ERCP with a long scope called introscope. However, when we are going back from the duodenum, from D3 to D1, we will get this inverted image. This is center image is like normal papilla. At 11 o'clock, you will see the bile duct, and 1 o'clock you will see the pancreatic duct. However, in this particular case, now we are putting a pancreatic stent. We are seeing the papilla from downward, like from D3. So this image will be inverted, and like this. In here you can see the CBD is in 5 o'clock direction. So now we are doing pre-cut to get a biliary access. So we're doing a needle, using a needle to cut the biliary sphincter above the pancreatic duct at 5 o'clock direction. Or due to this position, there is always chance of increased bleed in patient who are having this type of anatomy, and we need to do ERCP. So when this small ooze is occurring, we just applied a coagulation current and the bleeding has stopped. I have this another video where one of our initial case where we were doing endoscopic sleeve gastroplasty, and during one of the suture placement, one of the bite, we got this spurter at the level of proximal body. So we removed the helix of ESG equipment and applied a hemoclip and achieved the hemostasis, and subsequently we finished the procedure. So I'll just show this another 3 short videos which are not of the bariatric patient but can show the different types of endoscopic methods which can be used. This is failed endotherapy for the ulcer, and we are applying over the scope clip. Second video is showing hemospray. This is usually a temporary method. Once the hemostasis is achieved, you have to go back for the definitive therapy. And this last video is showing in POEM procedure, we get a spurter and we use the coag rasper. This is another device through which we can just apply the coagulation current and get the hemostasis. Thank you.
Thank you, sir. Thank you so much. I think we have looked upon into different aspects of hemostasis management. Now I will like to request Dr. Praveen Raj to share his video. Thank you, Dr. Nitin, and thanks to the entire team of AIG, GV Rao sir, for allowing you to be sharing your videos, sir. Praveen sir, over to you.
So I think bleeding is something, which we have to look up. I think we had a very good, beautiful video of a Roux-en-Y gastric bypass bleeding and an ESG bleeding from Dr. Nitin. Of course, sleeve is probably one of the most commonest procedures that we do. And of course, when prevention is the best management, but re-laparoscopy is usually required only when there is a rapid hypotension. We need not go in just because we see some collection or we see some blood in the drain. Only for rapid hypotension that we are unable to control with conservative means that we will have to go in. And when we find the pulsatile bleeder, which can be appropriately controlled using a figure of 8 stitch, better, as of course there are surgeons who also use a clip, but many times you see oozing through the entire stapler line where you might have to plicate the entire stapler line. So this is one such video that we go inside. We see a large clots above the surface of the liver and also around the stomach. So you see the clots that has happened. So this is about in the post-op day number 0 itself, because of rapidly deteriorating hemoglobin and also drop and tachycardia and some hypotension, that's when we explode. So you see a lot of clots. The clots are all being sucked out and removed. Exposure is very important to understand where the bleeding is coming. Just as a tip, many times when the clots are big, try to use a 10 mm suction forceps. They are very good in sucking out the clots. Of course, many times the 5 mm are good enough. So we see a pulsatile bleeder there, where we are taking a figure of 8 stitch on the stapler line. Clips are usually from the preventional aspect because they can again slip, but when we're re-exploring is try to suture the entire thing. So wherever you find a bleeding, you try to suture. So that is what is being done to just control the bleeding line. So we need to make sure exposure is very important, wash it out very well, examine the entire stapler line, and then we should be through. Of course, again, repeat, prevention is most important, especially when we do your case itself. Always make sure. I think the tip that I always tell surgeons is from the baseline, try to increase the BP by at least 10 to 20 points. Check for hemostasis with slightly higher than the normal BP, because that is very important, because many times it might look very good intraoperatively, but when the BP goes up during extubation, the bleeding can actually start. Thank you, sir.
Thank you, Dr. Praveen. Arun Prasad sir, can we have your video, please?
Yeah, I'll just connect my video. So just allow me to share the screen.
Sir, you are allowed, sir, please.
Can you hear me?
Very well, sir. We are fine with your slides also.
Right. So this is one case of, there are multiple cases, but I think as we are overrunning, I'll skip my other bleeding because we've seen some good bleeding videos already. This is something which is slightly different, so I thought I'd like to share this. Now, this is a patient who had undergone a sleeve gastrectomy, and this is post-op day 1. Suddenly on post-op day 2, when we came for ward rounds, we saw this. And we thought that, there is a bleeding that has happened. And so this continued, and then this is the kind of appearance that was there. Patient's BP was also slightly on the lower side. He was having tachycardia. So at that time, we used to follow our guidelines of, re-laparoscopy immediately. So first what we did, we took the patient to theater and explored the local wound, because we thought that maybe this kind of ecchymosis which we see could be due to subcutaneous bleeding which has spread around. So we opened the wound, but we could not see any bleeder or any signs of bleeding. As the patient was in the OT, we decided to do a quick laparoscopy. When we did a laparoscopy, we found some clots, but these clots were under the port site, and the actual site of surgery did not show any site of bleeding. So we thought that yes, this is probably something related to the port site only. We had this patient on LMVH, and what we did was we stopped the LMVH, gave him some vitamin K and FFP, and this led to improvement, clinical improvement, as you can see on the picture there. It got further better, and this was on the fourth day. Then what happened, my resident who was on leave for the last few days, he returned, and in the morning he realized when he looked at the notes that this patient is not getting LMWH, and he thought he'll be told off by us in the round, so he quietly restarted. So when he restarted, things again, the ecchymosis increased, which had actually reduced over the days. So in a way, this was something that accidentally he confirmed that yes, this had something to do with the low molecular weight heparin, because when he restarted it, the ecchymosis reappeared. We discovered in the notes, stopped it, and then patient became better. So eventually he happened to stay with us for almost a week, and this got improved, and finally it all got cleared off very rapidly, and things were fine after that. So the other video I'll skip, which is of a sleeve gastrectomy. I would rather use the second video time in asking your various panelists their comments about LMWH and bleeding after bariatric surgery.
Vasant, I would like to take your experience first, Dr. Vasant.
So this, this particular picture looks like the abdominal wall ecchymosis. Seems like it's related to one of the ports. Probably a branch of the inferior epigastric vessels must have been, involved. And this is exactly the picture that you see when that happens, when you knock off one of the branches of the inferior epigastric. Usually, I don't immediately stop enoxaparin or VTE prophylaxis. Typically, I tend to mark it and see whether it is a stable ecchymosis or an expanding ecchymosis. If it is an expanding ecchymosis with the continuing drop in hemoglobin or hematocrit, and as long as the patient is hemodynamically stable, you can even make a case for a selective IR procedure. Run the patient to angiogram and see if you can do a super selective procedure, and you may be able to identify the bleeder and knock it off right there. That may be all what you need.
Sorry to interrupt. Actually, I don't have the picture, but he also developed ecchymosis at other places, especially around the cannula sites, which could not be explained.
Okay. Thank you, sir. Now I have the privilege of sharing video of Dr. Raman Goel, sir. Raman Goel, sir, are you able to see this, sir?
Yes.
I'm running them.
the post-operative bleeding rates are generally around 2% worldwide in the literature. And we also had something similar experience for a few years. And then we looked up the reason. So this video is of a sleeve gastrectomy, post-sleeve gastrectomy staple line bleed. And then we sutured exactly as Praveen has shown. But the main issue, I think, there are 3 points which are relevant, and I don't feel that this could be related to low molecular weight heparin. I mean, a staple line bleed like this, maybe because of the stapler itself, maybe because of the thickness of the tissue, and it's always a good idea, as Praveen has mentioned, that the anesthetist should be asked to increase the blood pressure at the end of the surgery in all the patients when we look for hemostasis, because that ensures that that 2% bleed rate has reduced to less than 0.5% bleed rate. So I think a dry staple line at the end of the surgery without checking the blood pressure of the patient is dangerous staple line, because when patient is extubated, it starts bleeding. Second thing is exploration. The weight has been propagated. We should not jump in fast. We should always do a CT scan, because when we are seeing a drop in hemoglobin, it could be an intraluminal bleed. And this exactly happened in one patient where we had a significant drop of hemoglobin of 4 g%. And we were almost ready to explore on the second day of the surgery. And 15 minutes before the patient was being transferred, patient had a huge melena episode. And this laparoscopy would have been negative and would have been. So I think doing a CT scan, quick CT scan, can show whether there is a large collection in that area. And these are the issues. And the third thing is, most of the time when we go inside, we will find a clot on the staple line or on the side. So every possible side, let's say in a Roux-en-Y gastric bypass, you see clots everywhere, but you don't know where the bleed is. So it's always a good idea to look on all the staple lines and maybe overrun it, because the bleeding has mostly stopped by the time you go in. But when you go in, you dislodge the clot, and in post-operative period, again, patient can bleed. So I think these are 3 key points that we should keep in mind when we are doing this. This is about this patient. Yeah. Thank you.
Thank you, Dr. Raman.
Just comment.
Yes, Dr.
Add something. I just wanted to say that, if you look at the MBSC data, and that's probably the largest database that has looked at this particular issue, staple line bleed, 90,000 plus patients, it very clearly showed that staple line reinforcement or buttressing does not seem to make a difference with the leak rate, but it does make a statistically significant difference with reducing the incidence of staple line bleed. So just wanted to put that out there. And I think Dr. Goel is absolutely right. Even looking at that video, you could see some malformed staples, even in the video itself, indicating that was in fact a mismatch between the staple line height that was chosen and the thickness of the tissue.
Yeah. Point well.
Can I add something?
Dr. Subiraj, please.
Yeah, I think also incorporating a routine endoscopy at the end of the procedure. I know this is debatable for some people. We do it as a protocol. So that is really, I think, helpful, because when you do large volumes, you do once in a while pick up a Ulcer, and you have to deal with it endoscopically sometimes in the post-operative period. So that is, I think, an add-on that, adds some amount of security.
Yeah.
Thank you, sir. Dr. Narvaria.
Yeah, I just wanted to share one experience of mine wherein a person had a GI bleed post-operatively. I was not in the city, I was in another city, and patient was advised endoscopy by my colleague, and gastroenterologist kept on doing endoscopy using the air, and that has distended. He could control the bleed, but the distension of this has led to back pressure and gangrene of the bypass stomach. And when I came back, it was completely gangrenous. Even the part of jejunum was gangrenous because of the distension, which has caused. And the only thing which I learned is that immediately I ordered a CO2 insufflator in the OT to be used with endoscope. So that is one which is very, very important. It could save this patient, but many people would have not saved this. I think this is one lesson which we need to learn here, that use CO2 and don't try to over distend this. If you try to keep the pressure low and keep sucking and reduce this complication of overstretching and ischemia.
Mahendra, that's a good point. But at the end of the day, adding another procedure when you're doing a morbid obesity surgery, we have endoscope in the operation theater, but who is going to do it? I mean, gastroenterologist obviously is not there. You cannot expect anesthetist to do it. You cannot expect your junior most person to do it because the patient is supine, patient is not in left lateral position, and there is an endotracheal tube. So either you do it yourself, because many surgeons who have been doing endoscopy for years can do it. But I think it is not a requirement. Some of the centers are actively promoting it, but majority of the surgeons do a leak test, and you can leave a large amount of saline inside at the end of the procedure after doing the leak test that washes away the clots and all. And that also helps. That's like a part of IRA's protocol.
Intraluminal bleed, I'm saying, intraluminal bleed, which was detected in post-operative period, which required endotherapy to control it. And that has led to gangrene of the bypass stomach.
I agree. But these are risks involved of doing an endoscopy in such patients.
Yeah.
Okay, Nitin.
Yes, sir.
Madam, I'll come to you next, madam. Nitin, please.
So, I think we should not do endoscopy in immediate post-operative period routinely. When you are doing it, you should do with minimal insufflation and with only carbon dioxide, nothing else.
Exactly.
That's the dictum.
True.
Yes.
Jayashree, ma'am.
See, I just wanted to point out one thing. Whenever we suspect the GI bleed post-bariatric surgery, it is very, very essential to differentiate between intraluminal and extraluminal bleed, because the treatments completely differ. What my experience for the intraluminal bleed till today is, I had massive intraluminal bleed in 3 of my patients in the last many years with the thousands of cases which we have done. And all the intraluminal bleeds needed only a very strong medical treatment. With medicines like terlipressin, with medicines like vasopressin, we could control all the intraluminal bleeds without any intervention. Of course, it doesn't mean that we should not have anybody with us. We must have a GI endoscopy expert with us, but it is very important to differentiate. Again, all patients may not be able to undergo a CT scan post-operatively because of their sizes. And so typically remember the peritoneal signs. If you can find out that peritoneal signs are present, then that becomes an extraluminal bleed. But otherwise, please do not forget the intraluminal part of the GI bleed also.
Yeah. Only one patient where we found bleeding from the Delifoy lesion in the bypass stomach, which we diagnosed on angiography, and we could not control by angio intervention, and which required re-laparoscopy and doing endoscopy through the bypass stomach and then clipping it. So that is what we have experienced. But since I don't do routine endoscopy, we missed this small Delifoy which was there and which was then required intervention. So it was a difficult task to manage this patient. That too, he was in other city. I had to fly there, and we could do it.
Dr. Praveen, do you want to share something? I saw your finger going.
No, sir.
Fine. Dr. Jayashree, ma'am.
No, I was just trying to mention about the Delifoy's lesion, which we have come across in one of the patients. And again, as Mahendra mentioned about it, it is not a controllable situation by endoscopy, but this Delifoy's had bleed. In my case, this Delifoy's lesion in the post-gastric bypass stomach had bled both ways, extraluminally and intraluminally. So one of the, you can say, nightmare cases which I must have dealt with till date, fortunately could save the patient.
I think all good things are to come to an end. And I think we are definitely getting into the really hard discussion. But then in view of consideration of the time of both the faculty and the participants, I'm going to allow 2 minutes for all the faculty to give their final words. 1 line about thromboprophylaxis and 1 line about bleed. What is the message you'd like to share? Dr. Praveen first.
So I think venous thromboembolism is probably the #1 reason for mortality post-bariatric surgery. So although I have published this article, are we overdosing? Sometimes overdosing is better than underdosing. So I think we need to be very careful with regard to that. We cannot be complacent with regard to venous thromboembolism related procedures.
Thank you, Dr. Praveen. Dr. Arun Prasad, please.
Arun is muted.
Arun sir, are you with us? Now I would like to move on to Subiraj. Can you sum up in 2 lines?
It is too difficult.
Thank you. Yeah, thank you, Dr. Kanagavel. I think I'd like to go a little wide of the topic. Today, VT prevention is a medical, ethical, and legal mandate. So please, risk assess both for VT risk as well as bleeding risk, and then reach a consensus on what you're going to do. And please examine your own data set. That is the best way to get to the best protocol and practice. Thank you.
Dr. Vasant, I'm going to ask one different question for you.
Yeah.
The BEAT study, thrombosis for weight loss, like focal thrombosis of perigastric vessels for weight loss. What is your take on this?
I don't think the
It's an experimental work, I do understand. Just coming on to therapy, we are talking about thrombosis and bleed as a thrombosis for sake of weight loss. What is your take on that particular procedure?
It won't work. We've down this road historically, decades past, we are just rehashing something that's already been tried many times, doomed to fail. You're always going to have recanalization, revascularization. It's not a long-term solution. You may have some short-term effect. It's not a long-term solution.
And for you to sum up in 2 lines about thromboprophylaxis and bleeds, what is your final take-home message?
So the risk of bleed with VT prophylaxis is about 1.6 to 2%, depending on what you look at. And most literature studies show the risk of VT to be even less than 1%. However, even if you have that 1 in 100 or a 1 in 1,000 patient who ends up getting a PE and dies of it, that price is not worth it. So I would say, irrespective of that 2% risk of bleeding complications with VT, I would still be a very strong advocate of going for it.
Thank you, Dr. Vasan. Dr. Narware, your closing comments.
Yeah, see, I think we need to stratify our patients. We need to find out using different scoring systems. We need to categorize them in mild, moderate, or severe, and depending on that, I think we should prescribe the DVT prophylaxis, short-term, long-term, or even oral anticoagulation on the for a long term, which is advisable. I think if we can save few patients by doing this, it is the best service to society.
Dr. Jayashree.
I will say that every life matters, and all bariatric surgical patients come with a baggage of multiple things. They are never simple patients. So please go ahead with a complete evaluation. The prophylaxis starts with a complete evaluation of the patient and keeping all the things ready in terms of all the following SOPs with the standard clinical pathways. Do not miss anything. Train your systems, train your teams in such a way that every life should be given the complete SOP and the clinical pathway treatments.
Thank you, madam. Dr. Nitin, your words.
I think for thromboprophylaxis prevention is the cure. For management of post-operative bleed, you need a gastroenterologist or you need you to learn endoscopy. And one more person we missed here is intervention radiologist. I think we all need to work together. As my first slide I have shown, it's teamwork to have a better outcomes.
Point is taken, sir. Is Dr. Arun back with us? I think he has some challenge in getting connected. Fine. I will take the final word from Dr. Raman Goel.
The president.
Okay.
Yes, sir.
Okay, Kanagvel, excellent program, and thanks to you and Sanofi for organizing this. As far as the message is concerned, I think all of us who are doing bariatric have come with a general surgical background. And now time has come that every general surgeon must rise above the fear of bleeding if they use a chemoprophylaxis. It looks very logical that you are giving a blood thinner and you may have a bleed, but the science tells otherwise. So science is not always logical, it's more of statistics. And that's a fortunate part of it. So I think now time has come that we move beyond bariatric. We talk to our colleagues, our friends of old times who are still doing general surgeries, and emphasize that every gallbladder, every appendix, everywhere we should use a Caprini score or other score and identify high-risk patients and give them. I have lost a friend of mine who had a sarcoma of a thigh and had an amputation in Mumbai, and he died of a pulmonary embolism. And I had met him a day earlier in the hospital, and I said, "Are you on the blood thinner?" And he says, "No, nobody told me to take blood thinner." And next day he died, and I felt so guilty about it that I should have insisted with the surgeon that why you not started this. So I think many lives are being lost every day. And as Suviraj has so nicely pointed out, it's a moral, legal, and ethical requirement today, and we should go with that. So thank you again for the organizers and co-panelists for teaching so much to us and to all the viewers today.
Thank you, sir. One important closing comment from my side. It is prudent and it is current evidence which states the thrombotic phase of peribariatric procedure goes beyond 6 months of the post-operative period. So I really don't know, in telling this statement, am I to advocate an extended prophylaxis for the mere biochemical fact that they are having an extended thrombotic potential? But then please be aware, in diligent watch or diligent hearing from the patient what little symptom from their side is the most important mandate. And I think we can overstep little on the investigations if there is an element of doubt. This is a message. With that, I thank all the co-faculty who in such a very short notice have shared brilliant videos, their thoughts. And I think we all together did a wonderful job. Thank you, Dr. Vasant, for joining in such a short notice. I personally thank IAGS President Raman Goel sir for making this an endorsed program. Dr. Narwari, I took little advantage over you asking various type of videos, what all you can show. Thank you, sir. Dr. Arun Prasad was kind enough and he contributed most of the academic material in the group. Dr. Jayashree ma'am, he said, anything for you. See, my job was only to assemble pieces rather than contribute really much. And Dr. Suviraj has always been my ever-trusted friend who willingly contributed. Dr. Praveen Raj, I think he is from our part of country and he is always willing. Sir, Panilla sir. Panilla sir means we will do it. That's it. So he didn't even ask question when, what. Sir, I'm there for your programs. Thank you, Dr. Praveen, for allowing me to take that privilege with you. And in fact, when I asked Dr. GV, that is one other important learning I learned from Dr. GV this time. Sir, if it is something on endotherapy for bariatric bleed, it should be Nitin. That is all. So it is the question of inclusive growth. An institution grows when you allow others to grow. So I thank you, Dr. G.V. Rao, sir. I'm not sure he's with us now, but I definitely, it's an important lesson. It is not possible for you as a single person to do everything. You should have a team. You should have a multidisciplinary team. And when you do sporadic endoscopies, you don't expect to be very fine in controlling these difficult bleedings. These difficult bleedings need a person who on a daily basis control GI bleeds. So I definitely feel all of us should have a very valid interventional gastroenterologist. And Dr. Vasant was telling something very pertinent. They are now doing super selective embolizations. Most of the surgeries could be avoided if somebody who is that capable is available in your team. So make sure you have a good interventional radiologist also, in case before jumping to surgery, before jumping onto one more procedure, See, anything non-operative is fine for the patient. It is definitely very hard to go and explain, even though I have explained about, see, when I go to Cleveland Clinic, you have to believe, I think Vasant will vouch for that fact, they give 2 full page of complication list. Today, if any one of us are going to show that to the patient, I'm sure all of us will go out of practice. I've seen Phil Sharp personally explaining to his patient, the list of complication runs to 2 pages. If you are going to show that to our patient, I'm sure none of us will be seeing 1 case a day also. Yeah. So I really don't know. Cleveland is definitely far stepping into the amount of information they give to the patient, but then we have to strike a balance. Dr. Arun Prasad, I saw you back with us. You want to give any closing message before I hand over to the Sanofi team?
No, I don't think he's there.
He was there with us, Dr. Arun Prasad.
He came back.
I'm there, but
yes.
I think it's already quite late. So
in 2 lines.
I'll avoid giving any comment.
In 2 lines.
But I just want to congratulate you for the wonderful program, which has covered so much. And I don't think in any conference we've ever had a coverage, such an exhaustive coverage of this topic. So in many ways, these webinars actually cover much more than what conferences have been covering. So congratulations. I really don't have to add anything. Thank you.
Thank you, sir. With that, I thank every one of my senior colleagues who made this show a possibility in such a short time. And I'm sure all of us enjoyed the academics. The quality of academics has been definitely good. The video shared definitely made everyone to learn. I'm sure they'll be now looking forward. Okay, if this is going to happen, I have a solution with me. So that was the baseline which I was working on. And I'm sure all of us have achieved that baseline in comfortable level. Sanofi, over to you for closing remarks, and we call it a day.
One question to you. Last.
Please, Dr. Narvaria.
Are you doing it from satellite, that webinar, because we can see Earth behind you?
No, sir. It's a virtual background. The Zoom gives that option, sir. All of you can choose. There is a button close to the stop video. If you choose that, you can choose the virtual background, sir. That's it. Nothing great. No big surgical bariatric technique or tip behind that.
Virtual background is only available in the newer models of the laptops and iPads. So the older ones will not accept it. They'll ask you for a green screen.
I never knew that, sir. I never knew that. Sorry. Maybe new version installation. I think Jayashree madam has gone to San Francisco right away.
That's right.
So I understand, sir. This is one other point which I was not aware. Probably upgrading version and the newer models of laptops may be another requirement for this virtual background. I definitely shared that very important point. Thank you for sharing, Dr. Arun Prasad. Is that fine? Can we call it a close? Sanofi, over to you.
Yeah. Hello, doctors. Thank you so much. This is Venkataraman from Sanofi. It's been our privilege and pleasure to be part of this evening. We are grateful to IAGES for the platform, and of course to Dr. Kanagavel. You have been the brain in the program, sir. Thank you so much for all your guidance and support. Personally, we have learned a lot from you in terms of your improvisation, involvement, and how we have put this across all together. So it will be, I'm sure, useful for us in the future programs as well. Thank you so much to you. Thanks to all the expert panel members. The popular Thirukural in Tamil says that the stomach needs food when only there is nothing for the ears. I think it has been a fantastic academic feast that all of you have provided. We don't realize it's close to 2.5 hours and almost 10:30 here. So thanks a lot to all of you. In Sanofi, we have a vision, sir, to make India venous thromboembolism free. And that vision would be possible only with all your support. Thanks a lot. I think today's program has been definitely a big support from that aspect as well. So thank you so much to all of you. I also thank all the participants who had joined us today. I'm sure the 2.5 hours that you had spent today definitely is worth the time. So thank you so much once again. Thanks a lot, Dr. Kanagavel, IAGES, and all the panelists and all the participants. And also I thank my colleagues from Sanofi, Revati, Mohan Raj, and the entire marketing team as well. So thank you so much.
I think I will take the permission of the president to state its word. I would like Sanofi to be part of IAGS, and maybe if we can create an academic program on a regular basis for us on this particular issue. Because bleeds happen because IAGS has multiple platforms on various different specialties: oncosurgery, upper GI surgery, colorectal surgery, HPV surgery, and then we have hernia as a specialty. We have bariatric as a specialty. I'm sure Sanofi can definitely be an academic partner with IAGS on a continuous basis. So this particular segment can be supported with the help of Sanofi. I think Raman Goel sir, I didn't discuss this with you before. I hope you will permit me on your behalf to ask this question. Is that fine, Dr. Raman Goel sir, for putting this proposal?
Yeah, Kanagwel, as you are aware, we have initiated a corporate council program of IAGS. So the major corporates are becoming part of the IAGS core group, and they help in designing the partnering in designing the program as well. So I think let's look ahead how the collaboration goes, but that is the way forward for sure for any association in times to come.
And I also take this opportunity, Vasant, you represent SAGES in various levels. Maybe I think it is time IAGS and SAGES start working on some niche areas, maybe in data sharing or some form of academic program. Like if you can propose, or if we can jointly propose something where IAGS and SAGES can work together on academic programs or some form of academic activities to start with. Later we can mature on to other research areas. Maybe if that can be done, IAGS will definitely look forward to have much collaborations with SAGES. What is your take on this, Vasant?
Oh, absolutely. We can identify areas of possible collaboration. We can work behind the scenes, and I would be happy to be the liaison to various SAGES committees. Like I said, I'm on the SAGES Bariatrics committee, so it should be pretty straightforward.
No, I'm just wondering if during SAGES, maybe we can have IAGS sessions. How difficult is that to happen? I'm not sure. It is a big target, but every society is like DDW has SSAT, ASG, they have concurrent sessions going upon. Is there a possibility IAGS can be somewhat working on to partner on those areas maybe?
I'll have to find out, but I can just tell you that the ASMBS Annual Obesity Week, their annual congress, historically has been in combination with the Obesity Society. ASMBS holds it together with them, but they de-associated that coupling, they decoupled, and I think going forward, ASMBS will hold its own annual congress, and apparently there were logistic concerns and issues that led to the decoupling, and that just happened. So I don't know the ramifications, so I don't want to promise anything without understanding the whole picture. But certainly I can work with the SAGES leadership, and I can coordinate with you to try and see what potential issues may be, what roadblocks are in our way, and make it happen.
Thank you. Raman sir, I think you will have the final word and we'll close.
Okay. Kanagwel, seems you are connecting us to the whole world tonight. No, I think we are already tying up with the various regional associations. So we have tie up already with Bangladesh, Maldives, Pakistan, and Sri Lanka are on the way. We are also collaborating with ALSGBI. So I think it's just a matter of time that we take a step across Atlantic. And Aurora Pryor was here this time for our national conference. So I think with Vasant, knowing Vasant well, will be a great help. And not the conference, we can think of many other research areas where we can coordinate at the moment. So thank you so much, and thanks for everybody who is here and who is watching us on the screen for this late evening. It's really late, Kanagwel. We need to wind up now. Good night.
Thank you, sir. Good night, everyone. And thank you, Sanofi, and thank you, my dear colleague faculties, for making a big show. Good night, everyone. Thank you, dear participants.
Thank you, doctor. Stay safe, and hope to meet you also.
Thank you. Bye-bye.
Thank you, sir.
Bye.